Before I go ahead and introduce the panelists, I just wanted to provide some background info for context setting purposes that I think will be important for this conversation. So Black women have had a difficult time accessing reproductive health care that meets their needs. Access to reproductive health care, which helps women plan their families, improves health outcomes for women and children. Now, to add some color to this, we see that the US maternal and infant mortality rates are higher than in most developed countries and are hitting Black women the hardest. Many Black women lack access of quality contraceptive care and counseling. For example, in a recent analysis of California women enrolled in Medicaid, Black women were less likely than white or Latina women to receive postpartum contraception. And when they did receive it, they were less likely to receive a highly effective method. Black women are also 3 to 4 times more likely to die from pregnancy-related causes than white women, and this is regardless of their income or education. Black women experience higher rates of many preventable diseases and chronic health conditions, including diabetes, hypertension. When or if Black women choose to become pregnant, these health conditions influence both maternal and infant health outcomes. Black women are more likely to experience racial discrimination and often delay prenatal care to avoid racist experiences within the healthcare system. Black women are 3 times more likely to have fibroids than white women, and the fibroids occur at younger ages and grow more quickly for Black women. Black women display signs of preeclampsia earlier in pregnancy than white women. This condition, which involves high blood pressure during pregnancy, can lead to severe complications, including death if improperly treated. Despite barriers such as places in the rural South having few Black midwives, midwives are proven to reduce rates of unnecessary interventions and improve outcomes for mom and babies. A recent report on birth settings in the US identified birth centers as an integral part of an effective health system. And a study published in 2018 found the rates of preterm birth, low birth weight, and C-sections were lower among birth center patients. But it is estimated that only 3% of all US birth centers are owned or led by people of color. So we hear the horror stories of Black women giving birth in America. In 2018, Serena Williams said, quote, "I almost died after giving birth to my daughter, Olympia," end quote. And most recently, we heard from Jodie Turner-Smith from Queen and Slim, who said, quote, "We had already decided on a home birth because of the concerns about negative birth outcomes for Black women in America," end quote. So every person should be safe and free in their body, but we see that unfortunately, this is not the case for Black people, especially Black women. During a recent statement, Planned Parenthood said, quote, "State violence makes the promise of freedom unattainable for Black people in this country. That includes reproductive freedom. If Black people do not have the bodily autonomy necessary to live their daily lives or protest the violence against their lives, without the fear of violence or murder, we can never truly achieve reproductive freedom or justice," end quote. I am joined here today by 2 wonderful panelists, Nina Monestime, MD, MPH, resident physician at the NYU Langone Medical Center, and Gabby Newton, MPH, and program manager for the Baltimore City Health Department. So thank you both for being here, and I'm especially excited for this conversation. So I wanted to start by discussing the exploitation of the Black body. The reproductive health field has long benefited from the exploitation of people of color. In fact, many of the modern contraceptives and medical procedures used today are a result of abusive experimentation on enslaved Black women, testing birth controls on Puerto Rican women, taking and profiting from Henrietta Lacks cells without her consent, and countless other violations of Black and brown bodies. So I'll start with you, Nina. Can you speak more to the exploitation of the Black body, especially for those who may not be familiar with this history?
Sure. So Fanta mentioned that I am a resident physician, but I'm a resident physician specifically in obstetrics and gynecology. So I am working with women every day, and there are a myriad of examples of exploitation, of specifically the exploitation of Black women. And a very specialty specific example that comes to mind is actually Dr. James Marion Sims, who trainees like myself in OBGYN look to as the father of modern gynecology. Mm-hmm. And he is extremely famous for his work on something called the vesico-vaginal fistula, which is basically an abnormal connection between your bladder and your vagina that can happen during something called obstructed childbirth. So in the late 19th century, he is best known for perfecting his technique to fix that particular complication, and he did that specifically on anesthetized slaves, which we always hear, but their names were, I think it's important to name them. Their names are actually Lucy, Anarcha, and Betsy. And he anesthesia did exist at the time, but it's documented that some physicians didn't trust anesthesia yet because it was something that was very new, the advent of it. He is documented as not using it because he had the false assumption or belief that Black women, Black people in general, didn't experience pain in the same way as white individuals. And specifically, Lucy endured over a 1 to 2 hour procedure with no anesthesia at all. And these experiments, or not experiments, but these surgeries went on for decades, maybe I think it's like 30 or 40 years. And now obviously we use that technique in order to repair this particular complication. And we have several surgical and gynecologic instruments named after SIMS, including the SIMS speculum, which is something that a lot of people have probably encountered during their own, a lot of women have probably encountered during their own GYN visits. But actually, I think more people now are becoming more aware of this kind of controversial and this controversial and unethical history. And we've actually, even just yesterday in the operating room, my attending, which is my superior who's completed training, he said that we don't refer to this as the SIMS speculum, we refer to it as the Lucy speculum. So, interesting.
Yeah.
Well, and then Gabby, can you point to any specific examples, especially in the public health world?
When I think of the exploitation of Black bodies, I think of eugenics and population control and the use of birth control throughout history to reduce the populations of Black, brown, and poor people in this country. And mass sterilization campaigns have been going on for decades now. And I think of, providers or even students performing unnecessary hysterectomies on Black women. And it was so common and supported by the federal government. I know in Mississippi, they referred to them as Mississippi appendectomies because it was so common. And at one point there were like over 150,000 women of childbearing age who were sterilized by the early 1970s, which is actually, I looked it up, it was actually the same rate that the Nazis were sterilizing Jews in the 1930s. And on that note, I know you mentioned Fanta, you mentioned Puerto Rico, and it is important to acknowledge that in the 50s, the International Planned Parenthood Federation with the federal government funded a mass campaign of sterilization of childbearing women in Puerto Rico, Trujillo, Puerto Rico. And at that time, this population had the highest proportion of sterilized childbearing women in the world at that time. And it wasn't that long ago. And yeah, so I think of eugenics and population control. Norplant is another example, which was a birth control that was used, they injected it in your arm. And that was used for decades as well. It was even a condition for probation for Black and Latinx women in the criminal justice system. Like they had to get Norplant as a part of their probation. And this was as recent as the 70s. So it's not that long ago. And aside from eugenics, I was also thinking about the Tuskegee syphilis study, which didn't directly impact Black women in particular, but 600 Black male sharecroppers in Alabama were part of this study They thought it would last 6 months, and it lasted for 40 years, I believe.
Mhm.
And they thought they were in a study to look at bad blood, and turns out they were in a study on syphilis, and 400 of the 600 participants ended up getting latent syphilis. They were never notified of their syphilis, which can bring about a lot of life-changing health outcomes. And I mention that because it is connected to Black women too, because they are a part of it. Yeah.
Mm-hmm.
And I think it's important to note that at that time, the treatment for syphilis, which is penicillin, did exist. It was just withheld from the participants. And actually it was the men were able to participate, or they were given free meals, free medical exams, and burial insurance for participation in the study. And I think that that's had large trickle-down effects when you think about just designing study, like I do biomedical research now, and just designing studies, the board that reviews the study before it even begins, the Tuskegee syphilis study definitely has large trickle-down events in how we kind of conduct research and what we deem as ethical. And there are much more stringent guidelines now that exist today because of the Tuskegee syphilis trial. But on another note, I think that, as Gabby was saying, like, we think these things are very much so in the past. The example that I gave about Dr. Sims was in the late 1700s. But examples that you gave were within the past century. And I think even now, there's very, very dangerous kind of aftermath from all of that. So like there was a study done where 200, I think more than 200 white medical students were surveyed recently, like within this past decade, about their perceptions of Black individuals and their level of pain. And more than half of those medical students believe that there are actual biological differences in the way that Black individuals feel pain, perceive pain, and literally on a neuronal level, how we experience pain, which is obviously not true. But I think that when you're training up medical students to become physicians that provide high quality care, like inherently there are going to be biases in the way that they treat those patients when they arrive in the ED, the emergency department, when they come to you in the clinic. So I just think that that's something to note, and that's very important to keep in mind when we're talking about, I know this is about Black women, but Black bodies in general.
Absolutely, absolutely. And on the subject of biases that we see that are existing within the healthcare system, I want to stick on this topic. And I want us to discuss what are some of the other biases that exist within the healthcare system that not only prevent access to adequate healthcare, but also just access to adequate care for women when they're giving birth, and especially Black women. So we'd love to just have a discussion about that, because I think that that's something that we should definitely spend some time on.
Yeah, so I can begin. I mean, let's see, it's an enormous topic, and I'm a Black woman, so I can't necessarily enter the minds of those white providers that interface and interact with the Black women when they arrive to labor and delivery triage, and they're subsequently sent to their birthing room to begin their labor course and labor with us. But I would say one of the things that I've kind of perceived is the bias of women, no matter what they do, no matter what their occupation is. They can be a PhD, they could be a lawyer, whatever. The bias that these women are somehow less educated. And the danger in believing that, even if it's a false assumption, is that I think it changes the counseling that we give patients. For example, you mentioned preeclampsia in the introduction to this session, which is a very serious disorder of high blood pressure that can result in death of the fetus. It can result in death of the mother. It can result in seizures in the mother during their labor course, and kind of.
Beyonce had that, right?
What was that?
Beyonce had that?
Yes, yeah, Beyonce did have that. And so I think when you're counseling patients, like even in the clinic, there, for example, like these women who are at high risk of developing preeclampsia, like we might offer some women baby aspirin at the beginning of their pregnancy, but if we think that these women are less educated, we might not provide them with all the different options. We might just be like, all right, let's move on to the next thing. Like I had 10, 15 minutes in this encounter. She hasn't brought it up herself. Even if she's an educated woman, she hasn't brought it up herself. I'm not really thinking of it. Move on to the next topic. So I think that I think education is a huge thing, and it unfortunately, implicitly and explicitly, inadvertently affects the way we counsel patients, which is issue number one.
And then Gabby, any of the biases that you've seen, you've experienced, or that you want to add to?
I was just thinking about like reproductive rights, that movement, as it compares to reproductive justice. And I'm thinking of like how a whole movement could, there, like your biases could impact a whole movement, while you have mostly white middle-class women fighting for the rights to end their pregnancy on their own terms. You have Black and brown women who are just fighting for the right to have babies, to conceive. Just that assumption that all women are fighting for this one right to abortion is a bias that can affect the movement. And so, yeah, that is something I've been thinking about when you asked that question.
Yeah, no, for sure. And then on this topic of the movement and, fighting for rights and justice, I want to also tie this into the Black Lives Matter movement. And at the beginning, I forgot to thank the organizers for putting this together, especially in the midst of what's going on right now. But I really want to, center this conversation on the Black Lives Matter movement, especially because oftentimes when we hear about, Black Lives Matter, it's usually in the context of police brutality, which obviously extremely important, needed, necessary, etc. But when we're on the streets protesting that Black Lives Matter, it's not only Black Lives Matter when we encounter police, it's also Black Lives Matter in healthcare, in housing, in education, in finance, all those matters, So I really want to talk about like the intersection of just like healthcare and then like the Black Lives Matter movement, but even more specifically, reproductive justice, especially because, we should have the right to, bear children and have those children live on. So I just want to kind of tie those two subjects in. So Gabby, if you want to touch on that.
I love it. Yeah, so reproductive justice, just that alone, that phrase, it really, using that human rights framework really connects women's health and lives to other social movements. So all of these rights that you listed, the right to education, the right to housing, the right to jobs and education, all of those things are human rights. And knowing that reproductive justice is based on the human rights framework connects those dots to these other social movements. And so I think if we can continue to uplift reproductive justice and what that actually means in terms of these social movements that are happening right now, I think it will help us all to better see how these issues are all interconnected. I see reproductive justice shifting to a more collective framework, whereas the reproductive rights was based mostly on like the individual and the privacy. And so it kind of shifts that framework to thinking of reproductive justice as the collective, that it's a collective effort. We all have to work together and use our power to really, to fight for our rights to health and essentially quality life.
Absolutely. And then Nina, how do you think that we can elevate, this call for our right to live, in the medical field, at the operating table where you sit? How can we really ensure that that conversation is like also elevated in that space?
Oh, sorry. It's a good question. I think it's quite frankly a difficult question because as an individual who's spent the greater part of my adulthood thinking about these public health issues and disparities in healthcare, specifically as they relate to Black individuals, not just Black women, I think that the Black Lives Matter movement and, specifically Black reproductive justice are kind of inextricably linked. If we're talking about Black women being 3 to 4 times more likely to die of pregnancy and childbirth related complications, I think inherently the issue is racism. So it's kind of like, how do we solve racism? So that's a very difficult question for me to answer. I think one thing that we can do, even though I strongly disagree with the fact that the onus of resolution of this issue should be on Black people, but currently that is the way it is, and that is the state of current affairs here in US society. I think one thing that Black individuals and Black communities can do is, I don't want to say educate, because I think as a Black community, we do a good job of educating ourselves, especially when it comes to interfacing with the medical community. But I want to say health literacy, I guess. So it's not about, in my opinion, it's not about what you say to the doctor, but it really is how you say it. So I'm actually working on a new research study with the Northern Manhattan Perinatal Partnership, and one of their goals is to kind of provide, create a curriculum and to implement it in the West Harlem community here in New York City. And it's about health literacy and really talking to patients about what you need to say in order to really get the attention of the provider. So it's not about like, a pregnant patient comes in and she says, my leg is sore. As a caveat, pregnant women during pregnancy are at increased risk of blood clots. So the doctor might say, have you tried Tylenol? Have you tried whatever, like, to make this feel better? And like, kind of, you're fine, like, move on, like, we'll see you at the next visit. As opposed to the woman saying, my leg is sore, it hurts when I do this specific movement, could this be a blood clot? And kind of educating the communities about like what language, like what are you at risk of during pregnancy, or what are you at risk of during whatever part of your life that you're talking about, and like how to kind of, what language to use to kind of get the attention of the provider. I'm not saying that that's right, but I think that's one thing that unfortunately we need to learn how to do as a community. I encourage this in my cousins, my grandparents, my siblings, my mom, when she goes to the doctor, I'm like, this is what you need to say, and this is how you need to say it, in order for them to take you seriously. And so I know that's not really the answer maybe you were looking for, but I think that that's what we can do as a community. Because to be honest, it's a very multifaceted issue that I don't think there's a one-size-fits-all answer. There's just many different things and many different approaches that we can take to this issue.
Absolutely. I want to take a step back and kind of talk about the healthcare system a little more, especially in the midst of COVID as well. I think that the COVID-19 pandemic has just exposed how fragile and ill-equipped our healthcare system is, especially for communities of color, particularly Black people. So I kind of want to talk about the fact that the US maternal and infant mortality rates are higher than in most developed countries. And to many that may be surprising, just because we're believed to, be this great country in the world, but we also know that our healthcare system, is not as equipped as we think it is. So why do you think that, we have such a high maternal and infant mortality rate here compared to other developed countries?
So I think, first of all, globally, the US is notoriously known for its racism. Obviously, racism exists in other places, but it's particularly bad here because we also have economic resources that other other less developed countries have. And so it's kind of, I would say it's more visible here. But I think speaking specifically about the US infant and maternal mortality rate, some of this can be explained by our extremely high cesarean section rate. Black women are definitely more likely, I don't have a statistic for you, but in the literature, generally speaking, Black women are definitely at a higher risk of having a cesarean section. And C-sections, I think some people who are not in the medical community take somewhat lightly, but it's actually a surgical procedure that's associated with a very high additional risk of morbidity and mortality as compared to a vaginal delivery. And there's a whole host of complications that can occur. Increased bleeding, hemorrhage, post-operative complications such as infection, and a very serious systemic infection called sepsis that can kill you. And actually, Serena Williams, she had an emergency C-section, and that was actually complicated by like a wound dehiscence, meaning her wound came apart. There's just a whole host of complications that can occur, and I think C-sections are at least one of the roots of the extremely high infant and maternal mortality rate in the US right now. And actually, I'm thinking of it in terms of like bleeding out and what we call postpartum hemorrhage, which is typically considered the loss of 1.5 liters of your total circulating blood volume. Our total volume is about 5 liters, so that's a significant amount. I don't know if anyone listening right now has heard about Kira Johnson. They actually created on the television show The Good Doctor or The Resident, one of those television shows, an episode based on her story. So she was a Black woman who presented for a scheduled C-section at Cedars-Sinai in California. And so she had the uncomplicated C-section. However, for the next 10 to 12 hours, she complained of abdominal pain that was increasingly getting worse. And I actually saw her husband speak at a conference, and he said, you know, as a Black man, before we left, first of all, I was like, we need to dress a certain kind of way to go to the hospital so we can be respected. When we got to the hospital and she was complaining of this pain after the C-section, I was trying to advocate for her, but I didn't want to come off as the aggressive Black man. Issue number 2. So 12 hours went by, she was becoming increasingly more fatigued, and essentially they had said, okay, we're gonna get an image of your body just to make sure that everything's of your abdomen to make sure everything's okay. She didn't get the image until several hours later, 12 hours later. It came back and her abdomen was filled with 2 liters of blood. So she went to back to the operating room. They put her under general anesthesia to kind of evacuate all the blood, and she died instantly. And that's just one example of really the effects of not listening to Black women or Black patients in general and not taking their complaints seriously, which is why I made the comment previously of how like learning kind of what to say and how to say and when to say it might be helpful. And then 2, just an example of like the possible morbidity and mortality associated with a C-section. So I think like for me, that's definitely one of the reasons why our rate is so much higher than other developed countries, but I'm sure there are more.
Yeah, I think going off of what Nina just said, I think we need to work on also shifting the blame and onus on women, Black women, and really moving it back up towards health providers and the health system. I just think there's just too much burden placed on the individual when really this is a huge systemic problem. I'm just thinking about like recently at the Baltimore City Health Department where I work, we were talking about ways that we can improve programming across the city to improve hypertension among women and people in general, but pregnancy exacerbates these health conditions. And so we were having these conversations, and it seemed like half of the room was really trying to target changing the trainings for medical providers so that they can provide more information to patients about nutrition and diet and places they can go to access healthier foods. And then the other side was really talking mostly about providing like information and pamphlets for the patients. And I think we could do both. I don't think it's either or, but I personally feel like there needs to be more accountability higher up the ladder.
I would agree with that. One thing that comes to mind when you say that is an experience I had with a certain model of prenatal care delivery called Centering Pregnancy. And it's basically group prenatal care. And the idea is that a group of women, usually around 6 to 12, with similar gestational ages, meaning they're due at around similar times, they meet for 2 hours at a time. And kind of there's an OB provider, whether that's an obstetrician gynecologist or a certified nurse midwife, will basically provide prenatal care in a group setting. But the idea is that you can, one, there's a community aspect. So women that are going through similar things can kind of discuss pregnancy related issues. And then two, it kind of, the idea is to kind of empower the participants to like take greater ownership of their health. So when they come, they take their own blood pressure, they weigh themselves, and then they have a moment with the provider individually before stepping into the group setting. And that has been found, that group prenatal care model has been found to result in improved like birth and pregnancy outcomes as well. And I think that that's one way from the medical perspective, the medical system perspective, instead of, like you said, shifting that onus to the woman, it kind of is a way for the medical system to take more responsibility in addressing this disparity in outcomes between Black women and white women, or really just Black and brown women versus any non-minority group. But I participating in that for 10 months with a group of women. They were all Haitian and Creole speaking, like myself. And they said at the beginning, after we've kind of evaluated the programming, that this was way better. They got a chance to, one, it wasn't a traditional 15-minute visit where you're kind of rushed in and out of the door. Two, they were able to ask questions that they wouldn't have necessarily felt comfortable asking in a one-on-one setting, where inevitably and unfortunately there might be like a power dynamic in the interaction. So I think that that's one very kind of very hopeful solution to this problem, and it's definitely been more commonly used, I would say, in like urban communities. In urban communities, in like a community health center setting, but that's one thing that comes to mind.
Thank you. So I want to be cognizant of time, and we do have a few questions in the chat box. So I want to address one of those questions before we maybe kind of end with the topic of like birthing centers and like midwives, because I really do want to touch on that. And then also, Gabby, hear your thoughts on that. So the question here that says, is there an effective way to address hospital or doctor misconduct related to childbirth?
What I think about is something that we're also trying to improve on at the local health department level is, I don't, maybe, you might know, if I know like at a lot of like workplaces, they have something called like ombuds, or like a kind of like human resources, but a place where you can go to report your experience, to hold the people that work there accountable for what they do. So I believe that there's something like that in hospital settings where patients are able to report on their experience at their last visit and can report on how that visit went. And from my understanding, it sounds like there could be more work done to improve that system to hold providers more accountable for the care, the quality care that they provide their patients. Yeah, I'm thinking it could be one way.
So yes, Gabby, I think there is, at most like academic medical centers, there is like some sort of ombud system where you can go and kind of report like your experience with colleagues, physician to physician, and then I think patients can do the same, but physicians, attending physicians at least, are always tracked, and as OBGYNs, we're also surgeons, so our outcomes, you know, rates of postpartum hemorrhage, rates of infection, rates of readmission, all these things are definitely tracked and kind of reviewed on a definitely at least annual, probably semi-annual basis. And demographics wise, that is also reported. So, I mean, I'm sure there, I can't say for sure because I haven't reached that level of training yet, but I know that they're tracked by demographics and race, and that I'm sure if there was kind of something like some kind of outlier by race, that would be addressed. I'm not necessarily saying that position, there would be like consequences though. So that's not really something I can speak to yet because I'm just not in that level of training yet. So.
No, that's helpful. I just want to maybe spend the last, few minutes before we go into some call to actions, focusing on birthing centers because they are a very effective method. So maybe Gabby, I can turn it to you. I know that you previously worked as a doula. So I kind of wanted to speak more about, like the role of doulas and midwives and just birthing centers and how they could be used to address some of the complications that we're seeing from pregnancy, childbirth.
Yeah, I guess that was probably one of my call to actions too, was really advocating for more community-based doula care in medical settings and just in communities. There have been, it's proven that doula care really does improve many health outcomes and birth outcomes. So maybe I should back up and explain what a doula is. So there's doulas that provide full spectrum care from abortion support for someone who's under having an abortion, that procedure, to prenatal support, to providing non-clinical, emotional, physical support during labor, and then postpartum, providing support to the parent or parents after they give birth. And so having that extra support and advocacy for the pregnant person giving birth has been shown to lower the rates of C-sections, lower the rates of preterm and low birth weight births, and a whole slew of other benefits to having a doula or a birth worker present during labor. And so I practiced, I was a practicing birth doula a few years back, and it helped me better realize how important it is to have access to the service for everyone, to be able to access this service. And at the time, and I think even now in many places, having a doula is a privilege, and it's something that mostly only people who have those resources can pay for doula services out of pocket. But there is a growing movement to, I think in New York and a couple other states, I think Minnesota could be one, trying to get Medicaid to cover doula services would really make a huge difference, I believe, in these maternal outcomes that we discussed today, especially if it's community centered. So it's doulas that look like us, that have similar backgrounds and can provide services to those who need these services most. I know when I first got trained as a doula, most of the doula programs that were available to me were all put on by white women, and I was the only Black woman in this training, and never did we talk about the racial disparities in birth and birth health outcomes. And many of these doula trainings that I have come across, they focus on working independently and starting your own business once you're done with your training. And the difference with community-based doula care is that it really emphasizes having doula communities, support and mentorship of people who are living in these communities and provide services for people in these communities. And also, if there's a way to, if we can get healthcare to cover doula costs and pay doulas a living wage, I think that would be a great start. Yeah.
Great. No, thanks for sharing that. Yeah, so to end, any call to actions that you have, especially for the audience right now, anything that, because I know, Nina, you mentioned like health literacy, Gabby, you mentioned advocating for doulas. So are there any other call to actions, any concrete steps that people on the call right now can take in this fight for reproductive freedom?
I would say, generally speaking, a really easy step to take is really just figuring out the contact information for your representative and the mailing address, and actually either writing an email or writing a letter or making a phone call to your local representatives about these particular issues, whether they're surrounding access to birth control, access to safe abortions, access to whatever the issue may be, because at the representative state house, they do track, there is someone always there whose sole job is to track how many calls or how many contacts they get about a particular issue, and they file that down, how many times they've heard about that, and based on how much they hear about a particular issue, those are the issues that they prioritize for, the next certain amount of time. So I would say that if one of the we touched on a number of topics related to reproductive justice, and specifically as it relates to Black women, if one of those particular topics speaks to you, I would say start there by writing a simple email, because those things do matter and they do add up.
Thank you. Gabby, any final words, any actions for us?
I would say looking into other organizations that support this work. I'm a huge fan of the Black Mamas Matter Alliance, BMMA, and I feel like this group really sums up this whole panel, like what we were discussing today. They have their second national conference on Black maternal health in June. I would recommend checking out their website. They also provide toolkits for different organizations and medical providers to help create more equitable services.
Mhm.
And yeah, that's one organization. I think I wrote down another. The National Black Doulas Association is a relatively new association that is Black led, and it's all about doula care, and they provide doula trainings that are rooted in ancestral knowledge and literature. I'm actually going to be doing one of their trainings in a couple of months. I'm really excited.
Nice. Yeah.
So those are just a couple recommendations to learn more about the work that's being done around the country and the world, really. Yeah, they're international too.
Amazing. Well, thank you both for being on this panel with me. Such a great topic, so much to cover, so little time, but I think that you both really did a great job of capturing some of the core issues here. So thank you for definitely taking out the time to be with us today. Thank you for everyone who attended. In the chat, I just posted the link to the closing remarks for Black Independence Day. So if you have time, please join that. But thank you again for joining, and I hope you all enjoy the conversation. Thank you.
Thank you.
Thank you.
Bye.